Good evening to everyone present here with us today. This is Shreyan from IGCP. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by our keynote speaker doctor for today's session. With much pleasure and honor, I would like to welcome a very renowned doctor, Dr. Vinay Goyal. Welcome to our platform.
Good evening, everybody.
Sir is
Uh,
the chairman at the Department of Neurology, Institute of Neuroscience, Medanta, Gurgaon. With the help of Sir and his wonderful insight, we will be taking a close look on today's topic, which is 10 points in acute stroke. Now, without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him. Over to you, sir.
Thank you for the kind introduction. Today, what I have done is rather than taking a didactic lecture on management of stroke, I have made 10 points. So, these are 10 important points which I want to emphasize for the audience. Yeah, thank you for the slides. And I bring greetings from Vedanta. Can I have the next slide? This is the flow of my talk. We'll be talking about clinical diagnosis, imaging, when it's ischemic hemorrhage or hemorrhagic, or it's an hemorrhage, hypertension, diabetes, risk factor, TOS classification, intravenous thrombolysis, mechanical thrombolysis, antiplatelets, and anticoagulants. Next, please. So, how to diagnose stroke? It's a clinical diagnosis. You have to have a suspicion that patient is going to have or has a stroke. This is called FAST. FAST. FAST means F is for face. If there is a deviation of face on any of either side, one should think it is a stroke. Arm, A for his arm. But when you arm when you outstretch your arm and if it's drooping, or you're outstretching your leg, if it is drooping, then one should think it is not okay. Then change in speech, any kind of change in speech which is acute. And T is for time. The time is brain, so you have to do something as fast as possible. Are these only the symptoms? Fast? No. Let's check the next slide. Next slide. So these are other things. So numbness, rather than only motor, you can have only sensory symptom. So numbness of face or arm or limb. Then if patient is acutely confused, that can be another feature of acute stroke. Difficulty in looking, especially one eye or both the eyes. So if it is the ischemia of optic nerve, you can have vision difficulty in one eye. But if you have a bilateral occipital infarct, they may complain that they have some difficulty in looking at it. They don't go blind, but they may say, I'm not able to see clearly. So any symptom of vision can again a feature of a stroke. Then trouble in walking, giddiness, and so if it is a posterior circulation stroke, where you have involvement of the brainstem and cerebellar, you may be ataxic, you may lose your balance, you may have a quadriparesis. So these symptoms again suggest an stroke. Severe headache, so unknown headache, there is no evident cause for it. One should think, is it an intracerebral hemorrhage, which may not have produced a motor or sensory symptom at that point of time, or it is a subarachnoid hemorrhage. So one should think any unexplained severe headache, what you call it is a thunderclap headache. Thunderclap headache is severe, sudden, once in a lifetime headache, which patient will say, no, I never had this kind of headache ever before. So that is called thunderclap headache. One should think, is it a stroke? When you have all these things, what you should do next? Next slide. So it time to look at the imaging. What you should do, CT scan or MRI? See, MRI has a better penetration. You can see better visualization of stroke within few minutes of a stroke, whereas in CT scan it is difficult to visualize. So why we do an imaging? It is not to confirm that there is an infarct. If clinically there is an hemiparesis, the patient, if you do an under CT scan, and if you don't find anything abnormal within few minutes of onset of symptom, so you ruled out intracerebral hemorrhage, that is good enough to treat this patient as a stroke. But if the CT scan has been done after half an hour, 1 hour, or 2 hours, you will find subtle features like putamen may be looking asymmetrically, it's more hazy. Great white matter junction might have blurred. The sulci might have effaced. So these are some of the things. If you look carefully, you'll be able to identify that there is a stroke which is evolving right now. And if required, one could do a CT perfusion, which is also a good criteria. I will tell you later on why we need to do CT perfusion. And when you know this is a stroke, and if the patient has come after the window period, we'll talk about what is window period, then you can do a CT or MR angio to see which vessels are blocked and then you can do mechanical thrombolysis. Next, please. So when it is intracerebral hemorrhage, there are three main components. Either it's in parenchymal hemorrhage. The two common sites of parenchymal hemorrhage are either it is a putamen or it is a thalamic hemorrhage. So just to remember, putamen hemorrhages usually look more elongated vertically, while as thalamic hemorrhage more look horizontally. Other sites are in the pons or in cerebellum, but first two sites are common. A fifth uncommon is lobar hemorrhage. Subarachnoid hemorrhage is when the predominant hemorrhage into the subarachnoid space. Common, common reason for parenchymal hemorrhage is hypertension, avian bleed, whereas subarachnoid hemorrhage common symptom is aneurysmal bleed. And aneurysm bleed is a very serious and ominous thing. It's something like tickling time bomb. If you don't identify subarachnoid hemorrhage and this aneurysm will rupture, it can be catastrophic. Intraventricular bleed can be either a primary intraventricular bleed, which is usually because of hypertension, or subpile angiomas or AVM. And very commonly, we see the patient who has a hypertensive parenchymal bleed, which will dissect into the interventricular hemorrhage, interventricular space, and lead to interventricular hemorrhage. So I have one question. One person who has an parenchymal bleed without intraventricular hemorrhage, other patient has parenchymal bleed with intraventricular hemorrhage. The person with intraventricular hemorrhage has a poor prognosis. Why? Because the CSF will go and clot into the CSF. This blood will go and clot into the CSF spaces at the base, third and fourth ventricle. It will not allow the CSF to flow downward, and that will lead to hydrocephalus and patient will herniate. So intraventricular hemorrhage associated with parenchymal hemorrhage is more dangerous than isolated parenchymal hemorrhage. Next, what are the types of ischemic stroke? TIA. I remember when we were young student, we were told that any ischemic stroke which is less than 24 hours is called TIA. I think 24 hours window was, was in non-CT era time. Now the management is, I'm not going to wait for 24 hours. So any stroke which is any ischemic stroke which is less than 5 minutes, practically we can call it a TIA. Other thing, if you look at 100 cases of patients who have been diagnosed with TIA, and if you do good quality MRI, you will find some other infarct, small infarct. So definition of ischemic stroke, TIA versus infarct will change because now we are doing an imaging. CT may miss that infarct, but MRI will show that infarct in diffusion weighted images. So now it is not TIA, but it is a small infarct. So the management will change. What is the importance of TIA? Only 15% of the patient get TIA. 85% get first episode at stroke. So these are lucky 15% of the patient who are warned. And after that, almost 50% will develop stroke later on if not treated well in time. Now is how to define small and large size. Any infarct which is more than one third of the hemisphere is called large size. Okay, so that we have to take care of it. Initially, if you have a patient who has a large infarct, which is more than one third of the infarct, it's very common to give aspirin and other antiplatelets. But I would suggest, depending on the CT scan and looking at the type of infarct, size of infarct, and how much is the edema around, do not give aspirin immediately if you think it is a very large infarct and it will ultimately require a decompression surgery, which will. So, if there is a large infarct, from 3 to 7 days period of time, there will be massive cerebral edema. And when there is cerebral edema, because the brain is a compact structure, it will herniate and that can be catastrophic. So in those cases where it's a clinical judgment, if you think this patient will require a decompression, please do not give aspirin as the first drug immediately. Wait for it, because immediately giving aspirin is not going to help you immediately. But if the patient is on aspirin, if it requires a decompression surgery, then it will be delayed because you will have to correct the hematological parameters before this patient can be operated. Next, hypertension. Hypertension is something which is the biggest culprit for any kind of whether ischemic stroke or a hemorrhagic stroke. If the patient has a ischemic stroke and the patient who was taking already any antihypertensive, please continue the antihypertensive. If blood pressure is more than 180 by 130, then one should immediately treat. Because at the initial period, the blood pressure is also because of the sympathetic drive, and this blood pressure will come down within 24 hours. If you give any anti or enthusiastic antihypertensive to bring down the blood pressure faster or a stronger decrease in blood pressure, that will further reduce the cerebral perfusion and it will increase the size of the infarct. So if the blood pressure is less than 180, just monitor it closely. Don't give short acting blood pressure which crashes the blood pressure. Give a little longer acting antihypertensive and give a small dose so that you can check for next 24 hours how much is the blood pressure. If the patient was already taking antihypertensive, please continue those antihypertensive. Our target is mean arterial blood pressure should be around 130. When you should treat if the blood pressure is more than 180, if there is associated aortic aneurysm, if there is a heart failure, if there is a papilledema, one should treat blood pressure more seriously than especially ischemic stroke. Next slide. But if the patient has an intercerebral hemorrhage, then you must treat hypertension more rapidly, more faster. You can give labetalol. In case of ischemic stroke, more faster antihypertensive has to be given if you are planning to thrombolize this patient. Because if the blood pressure is more than 180 or mean arterial blood pressure is more than 130, then you can give labetalol intravenously every 10 to 15 minutes to bring it down to less than 180 and give thrombolytic therapy. In hypertension, you have to bring it down to less than 130, and it's better to treat more rapidly because it is believed those patients who have intracerebral hemorrhage, if blood pressure is not controlled, it is likely it will worsen the intracerebral hemorrhage. Otherwise, we also know the blood pressure related intracerebral hemorrhage worsen over next 24 hours. So the hematoma size gradually may grow, and sometime uncommonly it can be massive increase in the intracerebral hemorrhage. How to manage hypertension? There was a JNC 7 joint. This commission was JNC 7, and then the recommendation came in JNC 8, which is not an recommendation; it's an opinion of the. What was the biggest difference between JNC 7 and JNC 8? They said no class of drug is superior to one or other. You can use any class of the drug. Previously, the strict control of 140 by 85 is not good because it was shown that it increases mortality. So now they flex it to 150 by 90. So that is the change in JNC 7 and 8. There are a lot of other changes which you can use from these articles. Next slide, please. Diabetes. Why we should bother about diabetes is a risk factor. But those patients whose blood sugar at the time of presentation is high, it is said to be a poor prognostic value. So we can start with short-acting insulin and control the blood pressure for next few days. And blood sugar has to be titrated to optimize the blood sugar. If it is less than 200, it is good. If it is more than that, it is better to give short-acting insulin and control it. Next slide. Next. What are the risk factors? Risk factors are modifiable and non modifiable. We know all modifiable risk factors hypertension, diabetes, smoking, alcohol, and lipids. But non modifiable risk factors are age. You cannot change the age, gender. Up to menopausal age, the incidence of stroke is more in men as compared to women. But after menopausal age, the incidence becomes equal in both the gender, and probably this estrogen has a neuroprotective effect on stroke. But the trial which was done to look at the utility of estrogen to prevent stroke did not work out. Gene is an important thing. Sometimes if you have a bad gene, then nothing will work. And sometimes we see younger 20, 30, 40-year-old young man who's non-smoker, non-alcoholic, non-hypertensive. His lipids are okay, but still he is getting a stroke. Why? The genes are defective. How to identify gene? Look at the family. There is a history of young stroke and young heart attack in the family, and that or sometimes sudden death in the family will tell you that their genes are defective, and there are some genes which are described. I'm not going into the detail, especially the small vessel related vasculopathy. There are some genes which may be causing these infarcts. Next, please. Now, how do you classify stroke? Why you need to classify? Because we want to know the management will depend on the type of the stroke. So, whether it's a large artery stroke, which is embolic or thrombotic, it's a small artery or occlusion or lacunar infarcts, or cardioembolic stroke, then the management will change. a stroke of other determined etiology. It could be vasculitis, a lot of other drugs, and we'll talk about it. Or sometimes it is of undetermined etiology. Next, please. So if it is a large arterial stroke, it is usually because of medium and large artery, and stroke is caused by generally atherosclerosis or thrombus formation, and that embolizes. That will lead to large artery stroke. And the classical thing we need to look at is carotids. If there is a more than 50% carotid stenosis, we can make it more responsible. These infarcts are usually more than 1.5 centimeter, and you can see very well see them on CT and MRI. Next. Small arteries are usually cardioembolic. They arise from the cardioembolic stroke usually arise from the either heart or from the aorta or other vasculature, and they are usually a smaller one. The higher risk factors are those patients who have an atrial fibrillation, which is valvular AF or non-valvular AF. Both are responsible for cardio. Or if there is a patient has a metallic valve, or there is a thrombus in the left atrium or ventricle, which can dislodge from there and could lead to stroke. Uncommonly, you can have an atrial thymoma or endocarditis. As we know, endocarditis is a very important risk factor. Congenital heart disease may have an associated with infarct. Next, please. Small velar arteriole are usually microangiopathies. So they make small, very small, less than 1.5 centimeter infarcts. And they are also responsible for leukorrheusis. As you could see, the white matter changes which are present in this patient, and you can scale them on Fasakas criteria from 1 to 4, and that tells you the severity of the this. What is the pathophysiology? There is a lipohyalinosis of the vessels, so the vessels get hyalinized and gradually they block and lead to small infarct. And these are the pathology where most of the therapies won't be very effective. Next, please. Other is the undetermined etiology. What are other determined etiology? Vasculitis, non-inflammatory vasculopathies, genetically linked microangiopathy, which I was telling will lead to small vessel infarcts. Other angiopathies, para-infectious, in as you see in tuberculomeningitis, you may have associated infarct. Hematological disorders like ITB is a very common example. Intracardiac paradoxical embolization because of the PDA, or iatrogenic insult, for example, trauma. Trauma can give rise to infarct. Fat, air, and tumor embolism, systemic hyperperfusion. So, hyperperfusion related studies, injuries will lead to infarct. Medication, especially the drugs, are drug addicting drugs, especially cocaine and heroin, are known to cause uh, stroke. Pregnancy related stroke is another important aspect. Next, please. Because in pregnancy, there is an hypercoagulable state, and that can lead to what are the strokes of undetermined etiology? Especially if we have two etiology together, the patient who has atrial fibrillation also has more than 50% of carotid stenosis. Now it's very difficult to know which is responsible for the stroke. Or if you don't find it, you can call it a cryptogenic stroke. But now we believe that all the patients whom we diagnose as a cryptogenic stroke, or you don't find it etiology, one should do in 24 hours Holter monitoring to look at cardiac rhythm. And quite some of them may have an intermittent arrhythmias, which are responsible for the intermittent stroke. And all these patients should be put on anticoagulant. Next, please. Intravenous thrombolysis. As we know, TPA is a drug which we use within 3 hours of stroke. All the trials, starting from Nestor trial and other trial, have shown that if you give intravenous thrombolysis within 3 hours of onset of stroke, they will definitely benefit. Please remember, when you say onset of time, it should be determined very well. Somebody who gets up in the morning, so it's a wake up stroke, that it does not mean it's a 3 hour stroke. Because now there are methods, there is a wake up trial, there are methods to identify what is the life of the stroke infarct, and you can do and perfusion study to see what is the mismatch, and you can find out whether this is an ideal patient to thrombolize or not. You can do a CT angio, which carotid cerebral, to find out if there is a complete block of the block of the vessel. Then you should understand, even if you thrombolize, patient may not improve, and that will be the case for doing a mechanical thrombectomy. But always thrombolize if the patient comes with a window period, in spite the fact that he may require a thrombolytic agent. And now this window period, what we call a golden hour period, has been extended in some of the trials up to 4.5 hours. But that's the time you must have a diffusion perfusion mismatch to identify, is this patient going to benefit from this? If you are not going to identify this, then your expensive drug will not show any effect. And after 4.5 hours, there are also chances that there may be more hyperperfusion study because the dead tissue is dead, and now you give a blood, so it will lead to a hemorrhage in the infarct. And posterior circulation, one, because it's a more resistant kind of vasculature, so the extension of the 4.5-hour boundary is sometime expected in posterior circulation, and one should always try, because the posterior circulation strokes are more dangerous, more life threatening. So I would do everything to save these patients. Next, please. So when you do mechanical thrombectomy, how you do it? So these are some of the demonstrative drives. So there are suction catheters. When you go to the you do angiogram, go up to the thrombus and do suck it with the mechanism. There are distal thrombolytic devices what you use, which could be a wire, corkscrew, or there are mesh and stand base. So you cross through the stand this soft tissue, soft thrombus, gradually pass through it, go distally, and then open that umbrella or whatever kind of instrument you are using, and then gradually pull it down and you pull down the thrombus. There are stand retrieval also, so you go to distally and employ the stand. So that stand will capture the thrombus and bring it down. Next, please. So this is, as you could see, you are opening up this mash distal to the clot, and when you then you withdraw it, then this all the clots will be entangled in this. You can do a suction also, but there are also chances that you will cause a distal emboli. To prevent this, now there have been also a umbrella which have been used, which is first you place the umbrella distally, then proximally either you can use suction catheter or mesh wire or stent and pull all these clots. Next, please. So this started some journey started somewhere around 1999 from Proact devices. Then came Mercy, the Multi Mercy, Penumbra, and lot many devices. Mr. Clean studies, a lot of studies which have shown the efficacy from one to other. So initially from 3 hours, then 4.5 hours, then there were studies up to 6 hours. People also tried up to 12 hours. Different type of devices. They have used suction catheter, corkscrew type, or mesh type, or a stent or retrieval. So the mechanism of doing mechanical thrombolysis has been gradually changing. Next, please. Now comes the antiplatelet. Which antiplatelet to use? That's a big question. Aspirin, we all know, is a COX inhibitor and is very well known. What is the dose of aspirin? I usually prescribe 75 milligram of aspirin, but 30 milligram to 1200 milligram of aspirin is equally efficacious. But it's been shown in the meta-analysis. But increasing dose of aspirin, the chances of fatal GI and intercerebral hemorrhage increases. So when I was a student, we used to give 325 milligram of aspirin. Then we came down to 150 milligram, and now everybody uses 75 milligram of aspirin. And still, I think there is a big scope that this drug dose can be further reduced. Other phosphodiesterase inhibitors, there are two, dipyridamole and celestozol. Both are available. The problem with the dipyridamole was that this drug had two trials, Euro 1 and Euro 2 trial, which was excellent trials. They showed one of the best relative risk reduction of about 35%, which no other drug has shown. And after that, company did not do any trials. There were no trial comparing with other drugs or aspirin or any other trial. So what happens? Sometimes when you don't repeat the trial or don't duplicate the data by others, one would wonder: is it was it really a good trial or a dependable trial? And gradually, because of also side effect leading to headache and other things, this drug has gone into the disrepute and is not being used very well. But somebody who gets a stroke on aspirin, dipyridamole is another option. Third group of drugs are ADP antagonists. Clopidogrel is one of the most commonly used drugs now. Ticlopidine had fallen into the disrepute some 20 years ago, and I don't think it's available also. The newer drug Prasugrel and Ticagrelor, when you find that clopidogrel there is an allergy to clopidogrel, then you can use some of the other drugs. Or if you find the patient developing a stroke on clopidogrel, then you can try Prasugrel or Ticagrelor, but the studies are very small and they have not proven their mental as the was the aspirin. Now there are newer molecules or the monoclonal antibodies which have been developed. These are three monoclonal antibodies in uncommon circumstances. There is a double drug failure, then you can use them and you don't want to give an anticoagulant. Next, please. These are some of the mechanism. I'm not going to into the detail. Next, next, please. So what happens when there is an atrial fibrillation? See, atrial fibrillation is a major cause of cardioembolic stroke. If you've done echo and echo does not show any clot in the heart, any of the chambers or major aorta, then you know atrial fibrillation. So identify atrial fibrillation. You can do a plain EEG, which may show an atrial fibrillation. If it is not demonstrable, and if you have very high doubt, practically every patient of stroke, ischemic stroke, must have a 24 hours Holter monitoring to identify if it is an atrial fibrillation. Why? The management will change. Patients with atrial fibrillation will not respond isolated to ecosprin or dual antiplatelet. They will have to be given anticoagulant. Now, the question is whether it's a valvular or non-valvular. I'll show you in the next slide what is the difference. If they clot in the heart, you have to give anticoagulant. If it's atherothrombotic, then you might have to give an anticoagulant. As I mentioned, do and Holter monitoring. What are those anticoagulants? The old time are acetone and warfarin, which are vitamin K dependent. These are non-vitamin K antagonist oral anticoagulant, which are Neuron, Dabogatrine, and then Apixaban and Rivaroxaban. There are many of these drugs. Choice will depend. Almost all are equally efficacious. The choice depends on patient wants to take a single drug dose or double dose. What is the age of the patient? Whether the patient is diabetic, if the patient is renal failure associated, then rivaroxaban and apixaban are better choice as compared to dabigatran. Next slide. When we have to choose the oral anticoagulant, then mechanical prosthetic valve, you have to give old time warfarin or this, and you cannot give Novak. But if the mild to moderate valvular heart disease, then Novak is a good choice. Patient has severe aortic stenosis, Novak is a good choice. Patient a bioprosthetic valve after more than 3 months postoperatively, it is not advisable if for rheumatic heart disease and acceptable if for degenerative mitral valve, because degenerative might throw a thrombus, then you may require an anticoagulant. For mitral valve repair of more than 3 months period of postoperatively, in some patients you may give Novak. Otherwise, if you have a device which have been put, then there is no prospective data yet, but most of these patients will be requiring a Novak therapy. Hypertrophic cardiomyopathy, then most of the time now people prefer to give Novak as compared to the old time vitamin K dependent anticoagulant. Why? Vitamin K dependent anticoagulant requires monitoring of INRs and monitoring every 2 weeks, 3 weeks, or 3 months, depending on the type of the profile. Every indication requires a different monitoring. Usually 2.5 to 3.5 INR is good enough. But if it is applied antiphospholipid antibody associated stroke, then probably INR requirement. They will require a lifelong anticoagulant, and these are the patient will require an anticoagulant of a INR of 3.5 to 4 or higher INR as compared to cardiac. Next slide, please. Thank you very much for patient hearing. If there are some questions, I'll be happy to answer them.
Thank you so much, sir, for your wonderful presentation. We do have some questions from our audience. Would you like to take that up?
Sure.
Yes, sir. So, sir, the first question from our audience is, how can we effectively manage blood pressure and blood glucose level in acute stroke patient to improve outcomes?
Yes, as I mentioned you, if the patient has a ischemic stroke and if the blood pressure is less than 180, just hold on. Don't give antihypertensive drug to control blood pressure because it will decrease blood pressure, it will decrease cerebral arterial pressure perfusion, and it will worsen the ischemic stroke. Only reason to bring down the blood pressure is when you want to give an TPA. If the blood pressure is more than 180, then you should give more meticulously. If it is an intracerebral hemorrhage, as I mentioned, you must treat give antihypertensive. If required, give a labetalol every 10 to 15 minutes to bring it down to expected blood pressure of 140 to 150. Next.
Thank you, sir. So, sir, the next question is, What are the emerging trends and ongoing research in acute stroke treatment and management that doctors should be aware for the future?
I think the most important awareness about the youngster or those who are practicing at little peripheries, they should learn to give TPA. See, for giving TPA, what you require is a CT scan. If your CT scan is okay, you can go ahead with TPA because that will save these patients. And TPA should be available with every CT scan center. So if your CT is not showing in hemorrhage, if you're clinically strong about it is a stroke, so it is a ischemic stroke, you can give TPA. And while after giving the TPA, you must transfer these patients to a higher center. Reason, there may be a complication in the form the TPA related interest hemorrhage, which can happen in 10% of the patient. Patient may not open up the vessel, so he is going to have a large infarct. These large infarct will develop a massive edema next 3 to 7 days period of time. They may require a decompression therapy. So in all these circumstances, patient need to reach at a higher center. Other, if you are given TPA patient not to improve it, then they must reach to a higher center where a mechanical thrombolysis can be done. A patient can be salvaged well in time. Best thing is they should reach within 4.5 hours period of time. Next.
Thank you, sir. The last question from our audience is: can you explain the concept of golden hour in stroke care and its implication for patient outcome?
Yeah, the golden hour initially, as I mentioned, was 3 hours period of time. Window of 3 hours. Why window of 3 hours? It is believed that up to 3 hours the tissue may not die permanently. See, with every beginning of the stroke, the tissue will start dying, and if you don't give them blood or oxygen supply, they will die. There are some those who have a partial blood supply will survive for a longer period of time. At the core of in fact, the tissue will die faster. So it is presumed that if you treat within 3 hours, likely you will do less of a damage. So, but you don't have to wait for 3 hours. If within 10 minutes, you give it within 10 minutes. So faster is better. So time is brain. That's why I call it time is brain.
Thank you so much, sir, for answering all our questions. So,
Yeah.
sir, before concluding today's session, any last remark from you?
I would say, identifying important symptoms stroke, all the doctors have a moral responsibility to educate the mass. Whenever you are in public place, if there is an opportunity, you must educate. For example, those patients who come to you late, you sit down with the family and tell them where did they go wrong, that they did not reach hospital in time. So next time, if so they are with the person who is unfortunately getting a stroke, they will know that this patient has to reach hospital very fast, and they will be able to save the life of the next patient. It is something like when you get a seizure, you educate attendants for what to do when you get a seizure. Like this is exactly what we teach in everybody what they should do if the patient becomes unconscious, how to give CPR. Unfortunately, I've been asked doing this exercise. I ask my patients when they come to me that in last 1 year, have they seen any health program on television? 90% will say no. Second question I ask them, have you read any health related article in newspaper? 90% they say no. I say in last 1 year, have you purchased any health magazine to look at it? The answer is no. Now you tell me, and when I was in AIMS for almost 25 years, there was about 20 to 30 public related programs were organized, but by different departments. And I'm sorry to say the attendance of those programs was very dismal. We used to call our ward patients to go to the attend this program, or they will announce in the campus as if they are inviting for a big show. So despite the fact that the institute was spending so much of money, every department making a best effort to make this program a big success, but the attending people were very small. Why? People don't consider health learning as an important part. If there is a cricket match, somebody told me very recently during India Pakistan match on online, there were 3.8 crore people logged in. If I'm doing this program online, hardly there will be 100 and 200, 300 people who are logged in with this program. So people don't want to listen to it. I always take an opportunity to. Yesterday night I was in Meerut to give a talk on stroke again. So we had discussion about the same thing. So every doctor has a responsibility to educate the society about seriousness of stroke.
Thank you so much, sir, for joining us today.
Ma'am.
Once again, it was wonderful meeting with you, sir, and
Thank you.
thank you again. With your
Thank you.
permission, I would like to conclude today's session. Thank you, sir.